you. First of all, I would like to say thank you very much to Tanja Stosic for inviting me here again. This is the second time I'm in Belgrade, and it's beautiful. Maybe not so nice weather today as last time I was here, but it's great. And my topic today will be pseudo-response and pseudoprogression in brain tumors. I will try to do this as didactic as possible. So we will start with the outline of the topic with the conventional MR, the way we are looking at brain tumors, using the conventional MRI imaging, and in the daily practice. And then I will focus a little bit on the three entities that gives us constant problems: the pseudoprogression, the pseudoresponse, and when we are dealing with radiation injury. So the classic way, the way that we normally do in our practice, when we want to decide if a tumor has progressed, we usually look at the contrast enhancement, and we are looking at the size of the lesion. And as you can see here, by looking at the contrast enhancement, you could see at baseline there's a little bit of enhancement, and here we could see how this tumor is progression with increasing contrast enhancement over time, indicating tumor progression. Another way is to look at the size, and this is also something we do in our daily practice. We measure the tumor. We could do this by doing the angles like this, or we could do it as doing volumes, depending on how you want to work in your practice. So what was the problem with this method is that it doesn't really include the whole tumor. We are only dealing with the contrast enhancing part of the tumor, and as everybody knows, the tumor usually extends beyond the contrast enhancement. And therefore, back in 2010, the RANO working group revised the McDonald criteria for brain tumor evaluation and for looking at tumor progression. And one of the major reasons was also that there have come new therapies, and that we have the problem with what we call pseudoprogression. So from that now on, we should never include a patient at least 3 months after radiation into any clinical trial, because this patient might have pseudoprogression. And if you include them in a clinical trial and the patient looks like the tumor is progressing, you might take a patient off a clinical trial where actually the therapy is working. So therefore, never include a patient into a trial until at least 3 months after radiation. Also, the RANO criteria decided a little more strict guidelines for how you're going to evaluate tumors and how they're progressing. So by looking at the RANO criteria now, what do we say about tumor progression? Well, before 12 weeks after chemotherapy is if you see new contrast enhancement outside the area of radiation. After 12 weeks of chemotherapy or radiation, if you have a 25% increase in the contrast enhancing area of the tumor, or if you have new contrast enhancement outside the radiation field, and also if you see significantly increase of T2 and flare signal abnormality around the tumor, that is indications of a tumor progression. And also if you have a clinical deterioration, not a result of other comorbidities in the patient. So let's start with pseudoprogression. This is something that have evolved over the last couple of years, and you see it usually in patients that have been treated with radiation and temozolomide or Temodar. And in the up to 30% of these patients will have, during their treatment with the first 3 to 4 months, you will see an increase in the contrast enhancement, an increase in the size of the tumor. But it's only a pseudoprogression, and this will slowly go back or even disappear without any change in therapy. It's more commonly seen in patients that has methylene of the MGMT gene promoter, which is a favorable thing to have if you have a glioma tumor. If you have the MGMT, that is favorable in the treatment. But you will also more often see pseudoprogression. And what is pseudoprogression is still a little bit debated, but it's indicated that it is an inflammatory reaction, usually involving maybe the vessels, so that you would have a leakage, an increased permeability over the vessel wall, and an increase in the permeability of the blood-brain barrier, and therefore you have a leakage of contrast enhancement looking like the tumor is increasing. And if you take these patients to surgery, quite often what you will see, there will be indications of radiation-induced necrosis in these contrast-enhancing parts of the tumor. So here is just an example, one of my old cases. This is a patient who had pre-treatment for radiation. You see there is maybe the tumor have been here. There's a little post-surgical resection site, a little bit of enhancement. And 1 month into the post-radiation therapy, the patient looked like this. And we were all concerned for this being a recurrent tumor. The patient went to surgery, and there was only radiation necrosis, no tumor cells at all. So this is a typical what you could see in pseudoprogression. Here is another case. Again, you could see pre-treatment. There is some contrast enhancement, a little bit of edema. 1 month post-radiation therapy, these lesions have increased in size. There's increase of contrast enhancement, and it looks like it's a progressive tumor. This was just followed. We didn't do anything. We didn't change therapy. We didn't add anything, and this slowly dissolved over a couple of months, and the patient was doing quite well. Here is another case taken from the literature where you could see pre-treatment, pre-surgery, then post-surgery. There is a little bit of enhancement, post-surgical changes. 3 months into therapy, we have this huge contrast-enhancing, ugly-looking lesion, and this patient would just continue under treatment. And 5 months, you could see now there is a reduction in the contrast enhancement, shrinkage of the region where the tumor was located. This again is pseudoprogression. Here is an example of given to me by Professor Jäger from London. You see at baseline, there's a lesion here with a little bit of enhancement in the periphery with a surrounding edema. 8 weeks into therapy, there's a progression of the pathological contrast enhancement. And you could also see an increase in the flare signal abnormality. We follow this patient, and at 16 weeks, we can now see that this contrast enhancement is slowly disappearing, getting a little bit more scattered. And at 6 months, there is barely any contrast enhancement to be seen, and there is no any obvious tumor. And you could also see that the flare signal abnormality is significantly decreased. This was another case of pseudoprogression. If we are trying to use some of the more advanced methods like spectroscopy or perfusion, it has been shown in studies that you would have in a contrast enhancing lesion like this was early post-surgical, and then 2 months into therapy you have this ugly looking again contrast enhancement. If you put voxels of spectroscopy in there, you will have an increase of the choline peak, similar like you might see in a recurrent tumor or in a progressive tumor. But you would have, on the perfusion data, you would have a decrease in the relative cerebral blood volume, significantly decrease compared to if it was a tumor where you would have an increase in the cerebral blood volume and blood flow, and it would be red on your perfusion maps. And this was also how this patient looked a little bit later when they were just following him. So there have been also a way of using voxel by voxel changes, so-called parametric response maps, where you're looking at in every individual voxel percentual change over time. And in a study that was performed at University of Michigan with an oncology group, we were able to demonstrate that patients with pseudoprogression versus those patients with tumor progression, we could see there was a difference in the way the scatter plots look. There is more stable changes in this term when it comes to cerebral blood volume compared to the patient that had a progressive disease. Also, if we look at the histograms, you could see that patients with a pseudoprogression had a completely different cerebral blood volume histogram compared to those patients that had a progressive tumor. Now, this is done on a group level, and I wouldn't be sure that it would work on a single patient, and that we have to be aware of when we are talking about a lot of this. We always see studies done on patient groups, not on one single patient. And in the daily practice, we have to deal with one single patient only. Using the cerebral blood flow, we were able to discriminate those patients that had a progressive disease compared to those patients that had pseudoprogression using this voxel by voxel change. And we could do that already very early into 3 weeks into therapy, quite quickly see which of patients are going to go to have a pseudoprogression compared to those that actually have a true progression. That was pseudoprogression. Now, pseudo-response is something different. And the pseudo-response is related to the fact that the glioblastoma multiforme are very vascular tumors and therefore have been very active to target with anti-angiogenic therapy. So what we will see in this patient cohort, or these patients treated with this kind of therapy, is that we will see a normalization of the abnormal permeability blood vessels, and that results in a very rapid decrease in contrast enhancement that can occur within hours after treatment. So it looks like the tumor, there is no contrast enhancement anymore, and it looks like the tumor have disappeared, which is of course not the case. So most commonly we are talking about, for example, Avastin, but also when we're using VEGF receptor tyrosine kinase inhibitors, we could have this rapid decrease in contrast enhancement and this very highly response rate for patients treated with anti-angiogenic therapy. In many of these patients, you will see a pseudo-response. It has been shown in some studies that the time where the patient actually is free from tumor progression has increased a little bit in up to 40% of these patients. But their overall survival, there is no obvious change between those that are treated with anti-angiogenic therapy versus those that are treated with something else. What is more interesting, though, is that we see a new type of changes in signal abnormalities on the MR, and that is that we get non-contrast enhancing increase of signal abnormalities on T2 and FLAIR, and I will show you a couple of cases where this is quite clear. So here we have one example. You can see the decrease in the contrast enhancement. It was pre-treatment, and just 3 months after treatment, you can see there's a significantly decrease in the contrast enhancement, but if you look at the FLAIR signal abnormality, you could see that this significantly have increased over time, indicating that this tumor is not responding. It's actually a progressive tumor. It's a tumor that is still there and have not disappeared, even if it looks so on the post-contrast enhanced images. Here is another case also taken from the literature. Again, you have a pathological contrast enhancement here in the region of the corpus callosum. You follow this patient 6 weeks into therapy. There is barely any contrast enhancement to be seen, but at the same time, if we had a little bit of signal abnormality on FLAIR here, it have now increased and involves most parts of the right hemisphere and also extending over into the left hemisphere. Again, a patient that actually is progressive in his tumor, even if the contrast enhancement looks like he was very well responding. Here is another case also, just to demonstrate again. You have the pathological contrast enhancement. You see that this patient undergoes treatment 6 weeks, 12 weeks, and 18 weeks into therapy. At 18 weeks, we barely see any contrast enhancement, but if we go back and take a look, you could see that already here at 12 weeks, they starts getting an increase in the FLAIR signal abnormality, indicating that this patient actually has a tumor progression at this time, even though at 18 weeks, there is no pathological contrast enhancement. Here's another case, similar again. Again, you could see overall baseline, you see how this patient very quickly, already at 4 weeks, there is a significant decrease in the contrast enhancement. And then, but you could also see here that you had a progression of the FLAIR signal abnormality at this time, even if the continuous decrease in the contrast enhancement. So also this patient was progressing at week 4 and did not look as good as it maybe was looking by looking at the contrast enhancement itself. Now, we could have, this is another patient, one of our patients, where we had, he was treated with Avastin. You could see initial study after surgery with a little bit of pathological, some pathological contrast enhancement here. You could see a couple of months later that this contrast enhancement has significantly decreased, and even more so just 1 month later. But if we look at this patient's FLAIR signal abnormalities, you could see that this was, when he started at baseline. This is now in January, when the contrast enhancement had started to fade away. You could see that there's a significantly increase in the FLAIR signal abnormality, and this patient was also slowly progressing. There had been a very interesting study by Mong. It was published a year and a half ago in American Journal of Neuroradiology, where they were looking at diffusion-weighted images to see how they actually were correlated to pseudoprogression. And this was in a study of 20 patients that was treated with Avastin, and what he could see was that if you look at the contrast-enhanced study, T1, 6 months and 12 months, you see there is a little bit of enhancement. You see the flare signal is slowly fading away a little bit, but it's still there. But what's interesting is that the diffusion-weighted images, you could see there's an increase in diffusion in the B1000 value, significantly, and a reduction in the ADC value that are fairly stable over time. And when he did this study, he could see that those patients that had these diffusion-weighted and ADC abnormalities, they actually had a longer survival compared to those that did not demonstrate any diffusion abnormalities. So it seems that somehow these are stable and somehow indicated a stable condition for the patient, and it's not worsening of the disease as one might believe when we think about diffusion. And restricted diffusion usually should be a high cellular density tumor. So in this case, when you treat with Avastin, that you see diffusion abnormalities and you see a decrease in the ADC, might be a positive prognostic value for that individual. Here's another study showing just the same, or another patient. This is given to me by Professor Rowley from United States. And you see again the T2 abnormalities. There's no obvious pathological contrast enhancement. There's a focal area of restricted diffusion, and there's a decrease in the ADC, indicating again that this patient actually is responding to the therapy. He has a better prognosis than if we didn't see the diffusion-weighted abnormalities. So using DCE perfusion has also been used to look at these patients. And here's a patient that had been treated again with antigenic therapy. You could see the initial study at baseline, where you have some enhancement and you have perfusion abnormalities. 6 weeks into therapy, the contrast enhancement is slowly fading away, and you see much less perfusion abnormality and normalization. And then when the patient is progressing, you see again increase in the perfusion abnormality with an increase in cerebral blood volume and blood flow. Here is one of the patients given to me by Professor Law, demonstrating the same thing. Here at the baseline, we have a ring-enhancing, contrast-enhancing lesion. That is a little bit of perfusion abnormalities, as you can see here on the K-trans, and also a little bit focal area of increased cerebral blood volume. Follow treatment 2 months into therapy. The perfusion cerebral blood volume has significantly decreased, and there is no abnormalities on the K-trans, and this patient was also at this time actually responding to the therapy. Finally, a few words about radiation necrosis, because these goes together. And radiation necrosis is actually occurring in almost up to 30% of patients that are treated with radiation. And that could happen in an early state, a delayed state, or even years after treatment. So it's very important that you, when you evaluate these kind of patients, that you know if the patient have been having radiation therapy, even if it have been years before. So what it is, it causes usually difficulties to separate patients that have radiation injury from those that might have a recurrent tumor. And that comes, it's often a clinical debate, what we are looking at. So we could divide them into acute, early delayed, and late delayed, and we know that it involves the neurons, the glia cells, and the vessels. And the underlying pathology is still a little bit unclear, but one thinks it's an effect of the fibrolytic enzyme system and immune mechanism. So what you have initially, you would have an injury to the capillary permeability, where you see an edema, and in the more chronic phase, you would have a vascular endothelial damage, and you could then see areas of pathological contrast enhancement because there is an increased permeability over the, and an increase in the blood-brain barrier damage. So you could have a variety of abnormalities with radiation necrosis. or radiation injury. Anything from just the diffuse leukoencephalopathy with white signal abnormalities in the white matter with increased T2 and flare signal, which is maybe the most common that we see in many patients that have been treated with radiation. But you could also have areas that previously were non-contrast enhancing, now becoming contrast enhancing. It could be at the region where the tumor was initially located, but it could also be at other areas in the brain, but still within the radiation field. You could have a soap bubble or Swiss cheese-like appearance of this contrast enhancement, and I will show you that in the next slide. And you could also have a contrast enhancement within the corpus callosum itself, who is quite vulnerable for radiation. So here is an example of all biopsy-proven cases of radiation necrosis. All these cases was surgically had surgery or had biopsy, and in all cases was only found to have radiation necrosis. So here we have what we call this little bit of Swiss cheese-like appearance with, as you can see, a little bit of feathery appearance of the contrast enhancement, not very sharp borders that you might see when you have a recurrent tumor. And these are the typical leukoencephalopathy changes that we see with signal abnormalities in the white matter on FLAIR and T2 weighted images. The only time that we could really expect radiation injury to be a normal part of the treatment is when you do radiosurgery, because then normally that is a result of the radiosurgery is that you would have a reaction in the brain parenchyma and you have actually what we would call radiation-induced injury or radiation necrosis, as in this case of this boy who was treated for a recurrent ependymoma. This is the initial study. He goes to surgery, to radiation surgery. And you could see here in November that now he has this focal ring-enhancing lesion, a little bit feathery appearance again of the contrast enhancement, not sharp borders, and he has a significant edema. This patient was just followed without any further treatment, and you can now see there's a shrinkage of this area where he had radiosurgery, and there's also a decrease of the flare abnormality. So the problem with radiation injury, though, the major issue is that it's very seldom purely a true clean lesion. You would have areas with tumor and areas with radiation necrosis, and that's what makes it so difficult. This is one of my cases that I was so proud when I initially did, because I was saying that, oh, this is radiation necrosis. I was looking at the perfusion, I was doing the spectroscopy, and in all this area here, it looks completely like it could be radiation necrosis. But this patient had a little focal area of hemorrhage in the center, and I couldn't do spectroscopy in that area because due to susceptibility artifacts. So my diagnosis was radiation necrosis. The patient went to surgery, and it came back, and all this here that I had said was radiation necrosis was radiation necrosis. But that little thing in the center that was bleeding, that was recurrent tumor. So it didn't help much. So luckily, the patient went and had his surgery. And I think this is what we deal with quite often, that we have a mixture of both radiation injury and recurrent tumor. So if we're going to evaluate these patients, we need to make spectroscopy, or we need to look at the whole tumor, the whole volume, and not just one slide before we make our decision. This is just to be exemplified by a very nice case given to me by Dr. Kali from Turkey, from Izmir. He has this patient. The question is now, is this radiation necrosis or is it recurrent tumor? And if you look, you could see it looks T2 flare abnormalities. There is no obvious, and this is the pre-contrast enhancement, and you could see post-contrast enhancement, very scattered areas of enhancement with focal areas of almost like necrosis. So what is now what? Well, looking with the diffusion, with perfusion, we could see that there are some areas that demonstrate increased perfusion, and that was recurrent tumor, where other areas of this lesion demonstrates very low cerebral blood volume, and that was then biopsied and was radiation necrosis. So this is what we quite often see. Looking at the post-contrast enhanced, it's very difficult to separate, say, this is tumor and this is radiation necrosis. It looks very similar. So perfusion could be helpful. Also, Menglo have shown that recurrent tumor, if you will have a much steeper curve, like this, compared to if you have radiation necrosis, the permeability curve will be much slower slope. So if you're using that technique, and that is just demonstrated in this case of a patient with a recurrent tumor, pathological contrast enhancement, increased cerebral blood volume, and a very steep curve up of the permeability compared to this radiation necrosis, where you have no cerebral blood volume increase, no K-trans increase, and a much slower slope when you're looking at the permeability. He also did a study of 20 patients where he could show that not only the cerebral blood volume within the lesion, but also in the paralesional region was significantly different in those patients that had radiation necrosis compared to those that had recurrent tumor, where those with the recurrent gliomas had much higher cerebral blood volume values, both in the lesion as well as in the paralesional area. Finally, one case here where you could see similar thing, patient with radiation necrosis, pathological contrast enhancement, T2, flare signal abnormality, but when you look at the cerebral blood volume map, there is no increase, there's a decrease of the cerebral blood volume in the area of the lesion compared to a recurrent tumor that has just a little bit of faint pathological enhancement, but if you look at the perfusion map, it's significantly elevated cerebral blood volume, indicating a recurrent tumor of quite high vascularity. So my take-home message is that pseudoprogression, pseudoresponse, and radiation necrosis always are diagnostic challenges for all of us. Pseudoprogression usually occur early in the treatment within the first 3 to 5 months. And here I used to say time. If you see a patient and you're concerned, could this be pseudoprogression, maybe just follow that patient. If that patient is doing well clinically, then maybe just follow that patient with a repeated study within a month to see if you would have a decrease of the pathological contrast enhancement. That would be a sign of pseudoprogression. If there is an increase again, continuous increase, then you're dealing with a true progression. Radiation necrosis usually comes later after 6 months up to a year, but you could see patients with radiation necrosis several years after treatment. Suddenly they will come with pathological contrast enhancement within the radiation field. So that is important to always have that clinical history and that background when you're dealing with that kind of patients. And pseudoresponse is something that we will see in patients treated with anti-angiogenic therapy. So the drug would tell you. So I think that biomarkers like perfusion or maybe even diffusion might be helpful in your evaluation and when you're going to try to predict the outcome of these patients. However, we have to be aware that all the studies that are done in patient cohorts, where we usually are dealing with one single patient at the time when we are reading the case, and that makes it even more complicated for us. So thank you very much for your attention.